PD-L1 was the first biomarker that we thought about using for checkpoint inhibitors, which makes sense because they're blocking PD-1 or PD-L1. And we know that the PD-L1 levels on the tumor, theoretically, if that's the target, it would make sense to look for that. There are a lot of different ways of looking for PD-L1, a lot of antibodies that were developed. Most seem to be fairly concordant. So as we look across drugs, each of which has its own antibody to look for PD-L1, those numbers were fairly, if you took one sample and tested it, you get pretty similar results for most of them. What turned out, though, was when we looked in the second line, so patients who'd already had chemo, there wasn't always a correlation between PD-L1 levels and benefit. In first line, the first-line pembrolizumab trial used a high cut point, and only those with high levels seemed to benefit. But a first-line nivolumab trial was a negative study. It didn't have as high of a cut point, but even in those that did have the high cut point, it didn't seem to benefit. So with nivolumab, there's been a lot of work looking at tumor mutation burden, which isn't as simple of an assay. You basically have to look at a lot of different genes to get a sense of the total number of different mutations in the tumor. Tends to be that patients with a heavy smoking history have more higher mutation burden, and those with less have less. And in general, there's more benefit in those who have more. So with nivolumab, at least, that's been a validated biomarker now in several tests, in several trials, including the most recent data that was first-line nivolumab, ipilimumab versus chemo. Those who had high tumor mutation burden seemed to benefit. But it's not a simple test. PD-L1 testing is a simple test. Immunohistochemistry, one slide, stain, it's either there or it's not there, different levels. Tumor mutation burden, you've got to do a lot of analyses. So it's not clear if we're going to be shifting completely to that assay. Also, it's been very interesting that the PD-L1 tracks with the pembrolizumab and less with the nivolumab. The tumor mutation burden hasn't been looked at as much with most of the other drugs, so we don't know. When we look at stage 3 in the Pacific trial, the PD-L1 levels seem to matter somewhat. If you had higher levels, you seem to have more benefit, but even those with low levels were benefiting. So it's not really helping to make that treatment decision. It might help somewhat with prognosis, but if you're deciding treat or not treat and you're going to treat everyone, it becomes less important. And of course, there are other markers being looked at. I think everybody I talk to at different academic centers around the country, around the world, we're all doing our own testing, trying to figure out what's going to be the best next marker, additive marker, but there's a lot of different theories there.